And so what I love about the conference concept, and when President Wilson first sat me down to discuss it, was that we were going to operate, hopefully today, to seed a conversation at the nexus between the great public health thought that happens at universities like this one, public health practice that happens in a number of public institutions, and then the fundamental work of local public health that's often done by nonprofit institutions and community institutions, and to come together, to seed ideas, to exchange, to think through how it is that we work together toward this ultimate aim, I think is a unique one. I want to talk a little bit about context. So my background is in the academy. I was a professor at Columbia University before I came here, and so I'm going to try and channel a little bit of that. Hopefully not too much of that, because I know we're going to get a little bit more in the near future. But to set the context for a lot of our consideration, and to give you a sense of what it was that I was seeing when I was outside of Detroit looking in, and then hopefully what I'm seeing inside of Detroit looking out. When I was living in New York, I would see headlines like this one: Detroit infant mortality rate is worse than Mexico's. And as a population health scientist, obviously, and somebody from Detroit, this is something that very much piqued my interest and got me to read and to think. But what's missed in conversations like this is that these problems are fundamentally local problems. You can't just outline the entire city of Detroit and then assume, for example, if a baby just crosses 8 Mile, that the kid has a substantially higher chance of dying. It's not that simple. These are extremely local challenges. And what you see here is a map of infant mortality by zip code in the city of Detroit. And you'll see that there's substantial amounts of clustering. I'm trying to find my, it shows up on my hand, there it is. So a substantial amount of clustering here on Detroit's west side. You see that downtown and midtown are predictably less affected by this outcome, right? I'd also see headlines like this one: the fittest and fattest cities in America. And aside from 2 small cities, which I actually wouldn't call cities, in Appalachia, we were number 3 on the fattest list. And what you see here again is that this is a very local problem. This is a map that was produced by Alex Hill before we were able to, where's Alex at? Before we were able to recruit him to come join the health department. So thank you, Alex, for coming through. Alex is, when I started really looking into Detroit, his name kept popping up as the guy who makes maps about Detroit. So as soon as I started on, I was like, I need the guy who makes maps about Detroit. But this is a map here that shows you obesity by census tract, as well as the number of corner stores in Detroit. It's corner stores, liquor stores, bodegas, depending upon what you want to call them. And you see again that obesity is a highly local problem. Not all of the census tracts in Detroit suffer the same risk, but you see that there's clustering, and there may be some implication of things like this. Oftentimes folks talk about food swamps versus food deserts. And in Detroit, we're not a food desert. You can get food in Detroit. It's just not the food necessarily you want to eat. And we'll talk a little bit about that a little bit later. And then lastly, Detroit's staggering murder and violent crime rate are a public health issue. And again, you look at a map of homicide in Detroit, and you see similar clustering, very similar to what we saw with infant mortality. And the point that I'm trying to make here is that public health is local, and public health is contextual. So let's consider the challenges that we face in Detroit. I just talked about 3 outcomes, but you could really extend. So we talked about infant mortality, we talked about obesity, we talked about violent crime. You could also talk about lead, you could talk about asthma. It really doesn't quite matter. We know that Detroit sits higher on the list of bad outcomes than a number of similar cities, places like Baltimore, places like Oakland. But let's consider why. So you see here median income by census tract. And I just want you to think about this clustering here relative to the clustering I just showed you in a number of outcomes that we discussed. We know that even in the highest levels, we know that we live in a low-income city. The median income in the city is substantially below $20,000. Oftentimes, when we think about public health challenges, we just lay them at the altar of poverty. We say this is a poor city, hence poor outcomes. But I just showed you when it comes to poor health outcomes, we perform worse than other comparable low-income cities, places like Baltimore, places like Oakland. And I want to submit to you that that has a lot to do with context. If you look, you could fit all of San Francisco, Boston, and Manhattan in the city of Detroit with room left over. So Detroit is a gigantic city, right? So what we have now is we have relatively low-income folks who live in a huge city. What else? If you look at just the percentage of folks who have left Detroit in the past completed decade alone, 2000, 2010, you see that most of the city has suffered a loss. We operate at about 1/3 the carrying capacity of the city of Detroit. So now we have low-income folks in a huge city that's pretty vacant. And I just want to think about the dynamics of vacancy here. It's not just huge blocks up and leave. It's that you've been living on the same block for 15, 20 years. You look right, you look left, and all of a sudden you're one of 2 houses that's occupied on that block, right? And then lastly, the tragic irony in the Motor City is that 40% of Detroiters don't have a car, and another 40% lack regular access to a car. They might have a car, but it's shared by 5 people. Or that when they turn the ignition, it doesn't quite click, right? So we have 20% of Detroiters who can regularly, reliably get into their car and get where they want to go. So I want to put this in context for you. We have a low-income community in a gigantic city that's highly vacant, and folks can't get around by car, okay? So one asks themselves, how are decisions like this made? How did Detroit become this way? And what we're here to discuss today is health inequalities. And the mayor, I think, really well laid out the set of attitudes about who gets to have good health and who doesn't. And you see here, this is a picture of a billboard and a lineup of the African-American community back in the 60s. And you see the world's highest standard of living, and you see this happy white family with little Fido in the car. There's no way like the American way, right? And then we see there's also no way like the American way. And so when we think about the set of decisions that have been made over the past several decades about who gets to have and who does not get to have, those decisions have shaped the kind of context within which we suffer public health in the city of Detroit. So I want to talk quickly just about the work of public health, because oftentimes it's easy to think about public health as being the aggregate of medicine, right? You do a lot of medicine, you're now doing public health. And I want to contrast different approaches to the way that we think about how we prevent disease in public health versus in medicine. But first, I want to start with definitions. Public health is what we as a society do to assure the conditions within which people can be healthy. And there are 3 pieces of this that I want to highlight. The first is that public health is about context, and we're going to get back to this. Okay, public health is about context, about conditions within which people can be healthy. It's also about populations, groups of people, rather than individuals. And then lastly, it's about health promotion, being healthy rather than not being sick. In that context, I now want you to think through just this thought exercise. Imagine the whole world was 176 blue people, all right? 176 blue people, that's the world, no diversity here, all right? And we can think about, we want to prevent a disease. Let's just say that this disease is cardiovascular disease. Who wants to give me a cardiovascular risk factor? Smoking, diabetes. Let's think about one that's on a scale. Obesity, high blood pressure. How about that one? It's a lot easier to quantify, right? So let's say high blood pressure. And what is the high risk high blood pressure? Where are my clinicians in the room? All right, 140 over 90. Okay. So now we have this population, yeah? Some of these people are high risk, right? We've now painted them green. The green folks are high risk. That means when it comes to hypertension, they are over 140, okay? Now we age that population forward. And if we age the population forward, we know some of them will get disease and some of them won't. All right, so all the folks with X's on their chest, they got the disease. You'll know that there are green people and blue people with X's on their chest, yeah? What makes the high risk is that as a proportion, more of the green people got the disease. However, disease is not just relegated to the people in the blue, all right? So I want to keep that in the back of your mind. The medical approach to preventing disease looks something like this. We line all those people up by risk, right? So that x-axis of risk factor you're seeing, that's just blood pressure. So goes all the way up to 140, moving to the right, all right? And then the prevalence of disease, or the prevalence of folks at that particular risk factor on the y-axis. So what we do in medicine is we decide that there's some arbitrary level above which folks are now considered high risk, right? Those are the folks who are over 140, yeah? So what do we do for them? Well, we sit them down, we have a great clinical conversation. We look them in the eye, we show them their test results, we say, hey, look, ma'am, you are over 140, hence you are hypertensive, hence you have a higher risk for cardiovascular disease, hence we need to do something about this. So we might put you on some kind of drug, put you on a diuretic. We might put you on an ACE inhibitor. If you're already on a couple drugs, we put you on something more. And if we do our job really well in medicine, what we do is we truncate that curve. We move everybody beyond 140. You're now into the curve, right? And we say we've done our job. We've prevented disease. Yes? The problem with that, though, is that I showed you that a lot of the blue people who never had high risk still got disease. And we can think anecdotally through what that looks like. We say, well, look, I had this cousin. He used to be the spitting image of health. And then all of a sudden he dropped dead of a heart attack. What happened? Where was medicine? Well, we didn't catch those people because they never showed their risk in the first place. So we see all of these people because they're high risk, but we miss all of these people, okay? I want to contrast that to the work of public health. And in public health, we start with the same risk factor. We start with the same risk distribution, all right? And our goal is to simply shift the risk distribution for everybody. How do we do that? It is about context. It is about conditions. And so the collective public health strategy sees this, takes that to this, and then ultimately we see less disease. That is the work of public health. And again, it is about context. It's about conditions. So I want us to just think about context for a second. This is from a very recent article, actually, that the New York Times did based off of a JAMA article. And what the JAMA article sought to do was to understand where disparities in risk were greater by city, right? With the implicit argument that fundamentally public health is about context. And what they looked at, you can see here. You see here the life expectancy of 40-year-olds with household incomes below $28,000. And in the red, you see higher or lower life expectancy, excuse me, okay? And in particular, they lined up the cities where the poor live longest and the poor live shortest. And I just want to highlight that Detroit showed up in both of those shortest lives lists. And they did the handy thing of actually comparing New York City, which is where I used to live, with the city of Detroit. And you'll see that above the 50th percentile of income, Detroiters and New Yorkers sort of do the same. But what happens below the 50th percentile is Detroiters fall off a cliff, okay? And I want us to think about why that is. I lived, when I went to med school, my med school was just below the Bronx, all right? And what you see here is a number of statistics that we usually use to compare places across levels of poverty. You see here segregation, owner-occupied housing, bachelor's degrees, percent in the workforce, poverty. They're all sort of similar when it comes to Detroit versus the Bronx. That would make you think that Detroit and the Bronx were somewhat similar. But in fact, if you look at the Bronx from the air, it looks kind of like this. Huge amounts of density. This is what the Bronx looks like on the ground, right? Compare that to Detroit. This is Detroit from the air, Detroit on the ground. Completely different reality on the ground, right? And that is about context. I want to show you a couple of other things where context matters. Here you see liquor licenses. Our liquor licenses have not been adjusted since 2000. So you think about the population in 2000 versus the population in 2015, and the proportion of liquor that's been sold has not changed, okay? And that's mapped on alcohol-related crimes. Public health is about context. You look here, medically underserved areas of the city of Detroit. The vast majority of the city of Detroit is underserved. You see here, we talked about the food desert versus the food swamp challenge. And you see here food access across the city. Remember, we have a low-income community that lives in a huge space that's really hard to scale. So if we can't do the work of projecting public health out into those spaces, well then we cannot do the work of public health. And so with that, I just want to say that I'm really excited to be here today, because here I think we can seed a conversation about what to do next. And at the health department, what we're trying to do is build a health department that can tackle these challenges. We know that we cannot continue to operate from the center of Detroit and think that we can project public health into the rest of the space. Rather, we have to be micro, we have to be agile, we have to be thoughtful, and we have to tackle social determinants upstream. We look forward to partnering together with you in that work.